Hi, my name is Claudia and I will be presenting a case study on a 30-year-old female named Claire. Claire lives at home with her parents and sister, has a limited social network, is rather closed off and isolated, and only feels connected to her sister and mother. Claire started therapy with me after she attempted suicide. During our sixth therapy session, Claire confided that she was experiencing suicidal thoughts again. It was known to me at the time that Claire suffered from depressive and anxious thoughts. However, she had not discussed a suicide plan until this session. Claire told me that it involved jumping off a bridge, however the exact location was not known. She did, however, seem ambivalent about dying. My initial reactions and feelings were doubt and anxiety. As this was my first suicidal client, I immediately started to question if I was competent to treat Claire and worried that if I was not effective in helping Claire, it may have resulted in something tragic. I felt anxious and stressed at the fact that I believed I had a responsibility to care and protect Claire from harm. However, I worried that she may be difficult to manage when experiencing suicidal thoughts. Reflecting on my initial reaction and feelings towards the case, I believe that there were two ethical issues at play. The first and arguably the most important was determining whether I was competent to treat Claire. The issue was that I had established rapport with Claire and believed that I had an ethical duty to respect Claire's rights and autonomy in accordance with standard A.2.1 of the Code of Ethics. Claire had put her trust in me and confided in me, and if I were to refer her on to another psychologist, Claire may have viewed this as demeaning and disrespectful. However, I also had an ethical duty to practice competently within my limits, in accordance with standard B.1.2 of the Code of Ethics. As I had little experience with suicide, I doubted my ability to treat Claire competently and professionally, outlined in standard B.3, professional responsibility. I had to therefore take steps to ensure that my practice would not result in harm to Claire. A decision therefore had to be made as to whether to refer Claire on to another psychologist or continue to treat Claire. Another ethical issue I was facing was if I would have to break confidentiality to report Claire's suicidal intentions, and not only threaten Claire's rights to privacy, but potentially ruin the therapeutic alliance I had formed with Claire over the past 6 sessions. When referring to the Code of Ethics, Standard A.5.1 states that psychologists need to safeguard the confidentiality of information obtained during their sessions. However, when dealing with suicidal clients who are at risk of harm to themselves and others, disclosing confidential information may be necessary to protect the client, as stated in A.5.2 of the Code of Ethics. When Claire revealed that she was experiencing suicidal ideation and had detailed a suicide plan to me, I immediately conducted a suicide risk assessment to determine the level of risk Claire posed to herself and others. I actively involved Claire by asking her questions about her suicidal thoughts and current plan, and used the New South Wales Health Suicide Risk Assessment, as seen in the diagram. I assessed Claire, determining that her level of risk was medium. One of the reasons why I believed Claire's risk to be medium was her ambivalence about dying, her closeness with her mother and sister, and lack of exact location in her suicide plan. Her ambivalence was suggestive that Claire was not completely hopeless. One of the factors of suicide detailed in the New South Wales Health Suicide Risk Assessment under medium risk. Because of this, I decided not to break confidentiality and would reassess her in 24 hours. The New South Wales Health Suicide Risk Assessment was incredibly helpful, easy to manage and clear. It clearly documented what was required, detailing risk and protective factors, and highlighted the importance of documenting the reasons for each decision made. Following this, in order to manage Claire's immediate safety, I advised Claire that she should get a family member or friend to stay with her to ensure she was safe. The next day, Claire advised me that she had told her sister about her suicidal thoughts. This, I believe, was a promising outcome in the treatment process, as it demonstrated that for Claire, suicide wasn't the only option. I felt quite uncomfortable with the next decision that I had made. I had to either refer Claire on to another psychologist, who was more experienced in dealing with suicide, or do nothing further and trust that Claire's family would protect her. The latter option was not viable and was unethical, as I had a duty to protect Claire to the best of my ability. I believed it was not best practice to discontinue treatment and leave it to Claire's family. I therefore decided to refer Claire on to another psychologist who was more experienced. As I had limited experience dealing with suicidal clients, this case truly opened my eyes to the challenges faced by psychologists when dealing with suicidal clients, and the importance of ensuring that strategies are in place to deal with these challenges effectively. It is important to acknowledge that the majority of psychologists will experience a suicidal client in their profession. In one survey conducted by Detzer, Mazur and Freeman in 2003, 99% of graduate trainees surveyed reported to have dealt with suicidal clients in their training. This highlights the importance of competency when dealing with suicidal clients, a position echoed by Jobs, Rudd, Overholser and Joyner in 2008. After referring Claire on, I researched empirically based treatments I could use next time. One current model that is proving effective is the CAMS model proposed by Jobs and Droz in 2004. It focuses on understanding suicide through direct collaboration with the client and treatment focused on managing suicidal intentions and reasons. A CAMS controlled comparison trial conducted by Ellis, Ruffino and Allen in 2017 on an inpatient psychiatric sample suggests that this particular treatment may result in faster improvement than those who did not undergo CAMS training. Although follow-up effectiveness was difficult to determine due to attrition, this shows promising results when treatment of suicidal ideation is specific to the underlying causes of that suicidal ideation. There is active collaboration with the client, and importantly, coping strategies are developed to manage further suicidal thoughts. I have also learned about the significant influence that a clinician's attitudes and beliefs can have when treating a client, and the importance of reflective thinking in order to ensure effective and ethical decision-making is involved. As explained by Coverdale, Roberts, and Louis, when treating suicidal clients, it is important to be aware of how attitudes, beliefs, and values may be influencing judgment, which in turn can affect treatment outcomes. The initial stress due to fear of something tragic occurring, doubt caused by questioning my competence, and even frustration that Claire could not have seen the positives of living, would all have infringed on my ability to work effectively. Lastly, I learned about the importance of establishing an open, trusting, therapeutic alliance with the client. As stated by Sagal and Racine in 2018, this aids in collaboration, as the client feels that they have the autonomy in the decisions made regarding treatment, and can open up about their suicidal ideation and thoughts, which is crucial for the psychologist to understand during treatment, as previously discussed. This case illustrates the grey area that ethics is and the importance of ethically justifying each decision made when treating suicidal clients. Due to the sensitive nature of the situation, the stress and anxiety that can arise when faced with life and death, it highlights the importance of ethical decision-making models and how they can guide one to ensure that the decisions made are ethically just. Referring to decision-making models when treating suicidal clients, as well as adhering to frameworks and guidelines, will ensure professional best practice and ethical standards are upheld. One notable model is the Kosher and Keith Spiegel's 2008 ethical decision-making model. The decisions involve consulting framework and guidelines, reflecting on factors such as beliefs and values which may influence your practice, and evaluating the rights of all people involved. These are all necessary when treating suicidal clients. The ethical implications regarding competency are also important to consider when dealing with suicidal clients. One ethical model to refer to that has been formulated specifically in relation to suicide is the 10 core competencies model proposed by Kramer in 2013. These 10 core competencies can act as a checklist to ensure that before treating a suicidal client, you can demonstrate your competency, which, further down the line, will ensure professional ethical practice. The core competencies include knowing and managing your attitudes towards suicide, developing a collaborative, empathetic relationship with your client, ensuring that you are aware of the evidence-based protective and risk factors, and others. This in itself can also assist in an ethical decision-making process, as it can act as a list, as it lists factors to consider when treating suicidal client. In future, there are a few things I would do differently. Firstly, rather than refer my client on, I would ensure that I am competent enough to manage my suicidal client. This would involve undertaking training in both assessment and management of suicidal ideation, such as the CAMS model discussed, and seeking consultation with senior colleagues or supervisors when in doubt on how to proceed. I would involve Claire's family members to ensure Claire's safety and work in unison to effectively treat Claire or other similar clients, drawing on one of the core competencies in the Kramer's 2013 model. Involving family would build on the therapeutic alliance formed between the client and I, which, considered by Sagal and Racine, is crucial to ethical practice as it allows clients to engage competently in the treatment process. When considering this case in terms of the broader field of psychology, it highlights the necessity of adequate training for graduate psychologists. As suggested by Ort, Jobs, Forsaker, and Schmidt in 2009, lack of training may be influencing psychologists' confidence to treat suicidal patients. During this case, I believed that due to little experience, I was not competent. However, with training and seeking advice from senior colleagues, I may not have had to refer Claire on to another psychologist. In response to the need for adequate training, Kramer et al. 2013 proposes that not just informational training is required, but proactive role-playing and peer discussion-focused training is a must. Thank you.